trial. Unfortunately, Dr. Danat, who's the presenter, didn't find his way here this morning, so we then will need to continue with America. Systemic detection and management of multivascular involvement of atherothrombosis in coronary patients in comparison with treatment of coronary disease only. And the trial will be presented by Professor Jean-Philippe Collet from France.
Thank you, Mr. Chairman, ladies and gentlemen. So it's my pleasure to deliver this first talk into the press. So the aggressive detection and management of the extension of atherothrombosis in high-risk coronary patient in comparison with standard of care for coronary atherosclerosis is an open randomized trial, which is an academic trial sponsored by the APHP, a consortium of public hospital. And I would like to thank the member of the steering committees and all the investigators who are committed to this study. So the background is very simple. As you know, atherosclerosis is a systemic disease. The coronary location is the most frequent one and the most severe one. And symptomatic multi-site artery disease is about 10 to 20%. And we know that it integrates the global cardiovascular risk. But whether the prevalence and the associated risk of asymptomatic MSAD in high-risk coronary risk patients are unknown. And this was the purpose of the study. And we ask ourselves whether systematic identification of asymptomatic multi-site artery disease and treatment when appropriate, combined with an aggressive secondary prevention, was relevant because it has not been previously evaluated. So this was the hypothesis of the America study. We targeted high-risk coronary patients and we randomized them to a proactive strategy of detection and management of the extension of atherosclerosis to other territories than coronary. And we combined that with an aggressive pharmacological secondary prevention. And we spotted very high-risk coronary patients. And we compared them to a conservative strategy based on a clinically guided identification of MSAD and a standard pharmacological treatment approach. And this was the conventional strategy. This is this study design. And as you can see, we selected patients with 3-vessel disease, recently diagnosed, or patients presenting with ACS and age 75 or more. So we really selected high-risk patients. And then they were randomized to a proactive or to the conventional strategy, and we evaluated the primary endpoint at 2 years follow-up. And this was a combined endpoint looking at all events that are related to the progression of atherosclerosis. So this was, of course, major cardiovascular events, but this was also organ failure, which are related to the progression of the disease, such as worsening of renal function, new onset of atrial fibrillation, cognitive dysfunction, all the endpoints that may relate to the progression of silent atherosclerosis. So these are the baseline characteristics of the population. As you can see, these are high-risk patients. About 60% were 75 years or more. We had 1/3 of women, 1/3 of diabetic patients. We had about 20% of patients presenting with PARA-MIs or PARA-PCIs, and finally 10% with symptomatic lower extremity artery disease or PARA-stroke. And this is the primary endpoint. We randomized in total more than 500 patients according to the sample size calculation, and we anticipated to have 30% of events at 2 years follow-up, and we ended up with almost 45%. And you can see that the hazard ratio is 1.03, which means that there is no difference between the proactive strategy versus the conventional strategy, which means that we do not need to systematically identify asymptomatic multi-site artery disease in these high-risk patients. And when looking at the secondary endpoints and the MACE, there were no difference. And when looking at any individual component of the primary endpoint, there were no differences. So it was very consistent between two groups. And again, when looking at all the pre-specified subgroups, age, LV function, previous known symptomatic artery disease, there were no differences. These are the key secondary outcomes. And you can see that it was mainly driven by revascularization, but you can see that there is no difference with respect to the incidence of myocardial infarction, stroke, critical limb ischemia, organ failure. So in conclusion, I think that there are some clinical implications. First, when looking at the proportion of patients in whom asymptomatic multi-site artery disease were found, it's only 20%. So it's 1 out of 5 patients. And in these specific patients, when we looked at the dedicated interventions that were related to the identification of this asymptomatic location, it was only 2% of patients. So to conclude, we can say that our study does not support the routine detection of asymptomatic multi-site artery disease, even in very high-risk coronary patients, as those recruited in the trial, while aggressive secondary prevention strategy was applied in both groups. So I think that this has some really practical implication for the daily practice in our patients. Thank you very much.
Thank you very much, Jean-Philippe, for the presentation of these interesting data. Are there questions, comments from the press on this topic? The first row.
Mitchell, Cardiology News. So when you say that the proactive strategy involved detection of atherothrombosis in other territories than the coronaries, what does that mean? Where were you looking for this?
So in this proactive strategy, there was non-invasive detection using ankle brachial index measures to detect lower extremity artery disease. And there were non-invasive imaging strategy like duplex ultrasound. It could be also CTs. This was left to the physician discretion. And this was performed in 100% of the patients who were randomized to the proactive strategy. There was a pharmacological approach, but there was also the lifestyle changes with respect to, exercise and stopping smoking. So this was a global strategy to reduce the global risk of these patients.
That was only applied to the proactive patients?
Yes.
Because it sounded like the patient population you were looking at, wouldn't you apply that kind of lifestyle intervention routinely to all these patients?
Yes, we do. But when you look at, the success, even in the routine practice, it's only 50%. And when you look at also a dedicated trial that are promoting, lifestyle changes, etc., it's almost the same rate, only 50 to 60%. And this is what we obtained in the America study. When you're looking at, smoking cessation, it was obtained only in 62% of the patients. Physical exercise was obtained only in 50% of the patient, whereas the pharmacological approach was broadly successful in this patient population. But it's not only a question of pharmacology, it's a global approach.
Additional questions? Yes, please.
Melissa Walton, ShirleyTheHeart.org. Haven't we seen other trials that looked this very same approach that did give a reduction in short-term mortality and rehospitalization, targeting all tight lesions instead of just the target lesion that produced the ACS?
Yeah, but
can you account for that?
Yeah, this is specifically for coronary lesions. But now, if you look at multi-site artery disease, which is the global spectrum of atherosclerosis, there is no data showing that identification with the ad hoc treatment may change outcome. For example, in the PAD guideline, it is stated that you should, in coronary artery disease patient, you should measure ABI, the ankle brachial index. And the idea behind is to identify lower extremity artery disease. So you end up with, patient with higher risk, of course. But then you don't know whether, applying this identification, you change the outcome. And this is the gap, the gap.
Yes, please.
Oh, hi. Sue Hughes from Medscape. I'm still slightly confused on how you identified the systemic lesions. Did you specify which arterial beds had to be looked at, or you said you left it to physician discretion? I don't understand what that means.
Well, what was mandated was the ankle bical index measure, and the whole body duplex ultrasound. And if there was any evidence of lesion, then a more invasive approach could be done. But this was left to the discretion of the physician. So it could be CTs, it could be angios, but the first step was duplex ultrasound.
Thank you.
There's another question, the second row.
I'm Divikli. Do you do some power calculation of this study? Because you only enrolled about 500 patients. I didn't know if the the sample is large enough to calculate the significance of the study.
Yeah, of course we did power sample calculation. So we based these calculations on the TIME study, which was published in JAMA 2003. And this study was dedicated to elderly patients undergoing PCI. And at 2 years follow-up, there were 35% of event in this PCI population. And in our power sample calculation, our goal was to test the superiority of the proactive strategy with a 40% risk reduction according to the primary endpoint. And based on 80% power, we needed 526 patients, and that's what we've done.
Additional question?
You didn't mention the difference between the two groups. I mean, the studying, the smoking cessation. What's the difference? Did you? I think if you have achieved a high level of achievement of this risk factors control, I think that's maybe the problem that you didn't come to the successful result.
Well, you have to keep in mind that the average age is 77. So you're dealing with elderly patients. And we know that, smoking cessation is very effective in this population, but it's very difficult to obtain. And this is, of course, a limitation of the study. Another limitation that you can also see is with respect to the secondary prevention pharmacology. And we tried to be as best as we can, but there is side effects of this treatment, and we know that they are more pronounced in these elderly patients. And because of the side effect, we could not obtain 100% aggressive pharmaco approach, but this is the real life.
François Schill, spokesperson for this press conference. Jean-Philippe, one of your findings was to detect some other lesions in 1 of 5 patients. Do you think that in the future, when you will have to decide for prolonged dual antiplatelet therapy or adding ezetimibe or even adding PCSK9 inhibition, this finding could help?
To be honest, I'm not sure. Because when we looked at the type of lesion we found, it was mainly lower extremity artery disease for about 25% of the patient, then aortic aneurysm, and I'm not sure whether more aggressive therapy in this patient improve outcome. And this is the difficulty of this kind of trial. And few people ask us also whether why we did not disconnect the identification and then the approach of aggressive treatment of these lesions and the pharma approaches. But you have to keep in mind that first selecting 3 vessel disease patients or ACS in elderly patient is not an easy task, and it's not an easy task to have also these patients in these trials. So it was a challenge.
additional questions? So, this is not the case, Foster. I think we have to say thank you.